Center, New Delhi. And our presenting medical college today is Sher-e-Bangla Medical College, Borishal, and our today's presenter is Dr. Snigdha Chakraborty. Before we start, I request our president and our chairpersons of the two program is Dr. Khurshid Jahan. She is the head of the Department of the Obstetric and Gynecology, Sher-e-Bangla Medical College, Borishal. I request our president of the Oncology Club, Professor Dr. M.A. Haisa, to give us permission for starting the session. Sir, please.
Bismillahirrahmanirrahim. All the participants, faculties from home and abroad, and the presenters, Assalamu alaikum. Very happy that we're continuing our program. We're having dignitaries like Shalini Rajaram, Jaydeep Bhomik, Varun Goel, and also Professor Ahuja, who is attending us regularly. Heartfelt thanks to all of you on behalf of myself and also Oncology Club. Without any delay, Dr. Sana, start.
Thank you, sir. Thank you very much for giving us permission. But before starting the original session, regularly we arrange the poll questions. Before the starting of the sessions, the poll questions will be sent and shown, and all the participants are requested for poll voting. At the end of the sessions, again the questions will be shown, and you will again participate in poll voting. Mahfuz, please show the poll questions, please. And for every questions, 20 minutes only, 20 seconds. Mahfuz, it is only 20 seconds. Please stop the poll voting. Okay. This is the end of the poll questions. Voting now, I request our presenter today's our faculty, local faculty is Dr. Snigdha Chakraborty. I request Dr. Snigdha Chakraborty to present your case. Snigdha, please. She is working in Sherbangla Medical College and Hospital, Borishal. Please share screen, Snigdha. Snigdha.
Yes, madam, I am sharing my screen.
Basically, we are trying our medical colleges to participate and trying to involve them in our this tumor board, and we are trying our best to accustom it with this type of tumor board, as because they are the treating the patients in spite of treating the obs and gynae patients, general gynae patients, also the gynecological malignancy patients who are they are treating maximum patients. They are admitted in the medical college hospital, and for that reason, we are the oncology clubs aim to make the expertise in that areas so that they can treat their patients as the guideline and evidence based. They can treat their patients. Yes. Proceed.
Honorable Chairperson, distinguished faculty members from home and abroad, respected teachers and viewers. Good evening and welcome to today's session. Today I'm going to discuss about a case which we have encountered a few months ago in our facility. Mrs. X, 52 years menopausal lady, admitted in Shere-Bangla Medical College Hospital, Borishal, with the complaints of rapidly growing lump at lower abdomen for last 4 months, dull aching pain, early satiety, dyspepsia, anorexia for last 3 months. She had no personal or family history of breast, ovarian, or colon cancer. On examination, her ECOG performance status was 1. She was moderately anemic. Breast and thyroid status was normal. No accessible lymphadenopathy. On abdominal examination, a large mass about 24 week size occupying the hypogastric and right umbilical region. The mass was tender, partly solid, partly cystic in consistency with ill-defined margin. On pelvic examination, hard, fixed, tender mass fell through all fornices and mass could not be separated from the uterus. Ultrasonography was done and sonographic finding was huge multiseptate mass about 18 into 10 centimeter, having both solid and cystic part extending from the pelvic cavity to mid-abdomen and both lumbar region, probably ovarian origin. High blood flow was noted in the solid component. The tumor markers were CA125 level was 4,518 unit per ml, CA 19.9 and CEA level was within normal limit. Her CT scan was done, which showed large mixed solid and cystic mass about 16 into 12 centimeter with internal septa in the lower abdomen and pelvic cavity, more in the right side. In the liver, there was a cystic space occupying lesion about 7 into 4 centimeter at right lobe. There was minimal ascites. What will be her management plan?
Shalini ma'am, please.
The question is to us. What is
Yes.
the management plan?
Yes.
Okay. So Looks like an ovarian malignancy, looking at the high CA125 levels, and the CT scan also shows an ovarian mass, a complex ovarian mass, and but the liver shows a cystic nodule. Cystic nodules are probably not. How are we going to confirm that this liver nodule is a metastatic nodule or not? Because normally we don't see a cystic mass in the liver. So we'll have to first identify what is the cystic mass in the liver. What would you have done, Dr. Jaydeep, if you had a cystic mass in the liver, which is 7 into 8 centimeters? Because normally we do have a solid mass, right? Yes, the metastatic lesions are not cystic. So that's a little bit of a, but what was the other characteristics of the liver mass?
Good evening, everybody. Can we go back to the image? Can you just go back to that image, the previous slide?
Previous slide, Sneak, the previous slide.
Okay, ma'am.
Right, okay. So as Shalini has very clearly pointed out, that whatever we are seeing in the pelvis and the lesion we see in the liver may not be the, I mean, there could be a metastasis, but could be a completely different thing. So, of course, on the first instance, we should investigate the liver lesion first and then proceed with whatever plan. Yeah. Do you agree, Shalini?
Yeah, I agree. So what did they do for the liver lesion? Was anything done for the liver lesion?
Yes, ma'am. Her ultrasonogram guided biopsy was done after that.
Okay.
And what was the report?
Next, go to the next slide. Yeah.
The ultrasonoguided FNAC was done, and the right adnexal mass, there was papillary serous adenocarcinoma, and at hepatic mass, it was metastatic papillary serous adenocarcinoma.
Okay. So what would you do at this point of time? What would you do as a clinician, or you as the oncologist, or looking after an oncology patient? What would your line of management be? And there's no other metastasis anywhere else? Nothing in the
No, ma'am.
lungs?
There was no other metastatic areas.
Okay.
About
And
the
what was
nodes? Paralytic nodes?
what about the nodes?
About what, ma'am? Please.
Nodes. Dr. Bhaumik was asking what about the nodes?
Nodes. Oh, there was no, at the CT scan report, there was no lymphadenopathy. There is no lymphadenopathy. In that aortic lymph node, there is no lymphadenopathy.
CT scan, CT plate.
CT scan, yes, ma'am.
Okay. So what would you have done?
Next.
Then patient was placed to tumor board for making a decision about her management plan. And according to the decision of the tumor board, the management plan was neoadjuvant chemotherapy followed by interval debulking surgery. And with this plan, the patient continued her chemotherapy, but after second cycle of chemotherapy, the patient was lost. And she again came on November 2020 with an abdominal mass at lower abdominal mass, and which was increasing in size. Her second cycle chemotherapy was in September, and she attended at our hospital at outpatient department on November.
So what now? Do you plan to take her up for surgery, or you want to give her more chemo, or what do you want to do? You want to assess her further, or?
What they should do now in this regard?
The first thing is that you have to make a,
Yes, sir. Yes, sir.
you have to make a reassessment. Okay?
Assessment.
Assessment where the patient responded to the according to the CT scan that you have sent, according to the details, she has a solitary ovarian mass, an isolated lesion in the liver, which is also a malignancy from the ovarian mass.
When the patient came at
Treatment of
November,
cancer is
then
surgery and chemotherapy.
So what did you do in November?
What did you do?
Patient was assessed at November and her sonography was done. CT scan, she could not avail CT scan due to financial status. And sonography finding was the mass again increased in size. It was about 16 into 10 centimeter size. And there was no sign of, at that time, there was no sign of hepatic nodules. That was vanished.
That was
Only
on
abdominal
ultrasound.
mass.
That was
Yes,
an ultrasound.
ultrasonographic finding. Yes, ma'am. And CA125 level was raised, and it was 3,420 unit per ml.
So what would you like to do? What is your decision now with the CA125 of 3,000 and the liver has disappeared, but the ovarian mass has increased?
Then again, the decision was, the patient was placed to tumor board, and the decision was to continue and complete her rest 4 cycles of chemotherapy. So she was given 4 cycle of chemotherapy with paclitaxel and carboplatin up to January 2021, 21st January 2021.
So what happened after that?
Then we reassessed the patient and assessment for surgery was done at that time. And then we examined the patient on general examination. Her status was normal. Abdominal examination, the pelvic mass was about 12 weeks size, and paravaginal examination, uterus was anteverted in position and fornices were free. And sonographic finding was there was the irregular hypoechoic soft tissue mass at right side about 6.3 into 3.7 centimeter, and at left side was 6 centimeter into 4.5 centimeter. No ascitic fluid. Liver was normal in size and echogenicity, and CA125 level was at that time 323 unit per ml.
Okay, so it's become very easy now for you to decide on what to do.
Yes, ma'am.
So did you all operate on her in January or February?
At March, patient came
March.
at March.
Okay.
Yes, ma'am.
So what did you all do?
Then laparotomy was done on 21st March, and the paraoperative finding was there was minimal ascitic fluid which was reddish in color. There was used adhesion of the uterus and the adnexal mass with the surrounding structures, and there was multiple metastatic deposits all over the parietal peritoneum, guards, and pelvic peritoneum. But the surface of the liver was, there was no nodule on the surface of the liver. So total abdominal hysterectomy with bilateral salpingo-oophorectomy and omentectomy is done at that time.
Do you think this was sufficient surgery for this patient?
No, ma'am, this was not sufficient surgery. I think at that time.
So, if,
Development
no. So, could she have been sent somewhere else to an onco center?
Yes, ma'am. We offered her, and we also tried to refer her, but because her financial status, and at that time the COVID situation was not so good in that situation, so she could not able to go to the higher center. So we performed the surgery at our facility.
So what should have been a complete surgery? What should have what were the components for a complete surgery? And what do you want to do at the end? What do you want to achieve at the end of surgery?
I will request my madam to answer this question.
They remove the surgery as the complete cytoreduction, but as there is the treatment response, there is because she discontinued the chemotherapy, and there is a big gap, around 3 months gap between her first 2 cycles and other 4 cycles. During that time, and this surgery was not complete. It was just debulking surgery only.
No, Madam Shahana, she came back there before she was operated. She had very good findings, right? The masses had really shrunk. The CA125 had come down. So there was no reason why a complete surgery couldn't have been done, right?
Yes.
When she came, she responded to treatment. She responded to the next 2 cycles of treatment.
Yes.
And it did come down. The size came down. The CA125 came down, and she was ready for a complete surgery.
Yes.
So whenever you are treating a patient, there are 2 important things to consider. Number 1 is what is ideal, and number 2 is what is feasible and practical for that particular patient. So in an ideal situation, if this patient was affording coming to a tertiary center where you have all the available resources to treat her, we would have probably gone for a primary surgery, because there's only one area of metastasis in the liver, which is on the surface of the liver, which can be easily resected out. And of course, you do hysterectomy, omentectomy, pelvic parotid node dissection, everything. So that is the idea.
Dr. Jaydeep, was it in the parenchyma of the liver? I think it was a parenchymal lesion, not on the surface.
If I look at as much as I could see, it's actually on the surface. So from the surface of the liver, resection is possible.
Yeah, but this looked like, anyway, parenchymal.
But
Okay.
Small
Yeah. If it wasn't parenchymal, then you could have done that upfront primary
it
surgery.
was not only the liver, but there was multiple metastatic deposits throughout the parietal peritoneum, the mesentery, the small gut, large gut, everywhere there was the metastatic deposit.
So that's why the assessment of the initial assessment is very important. That she must assist, because when I asked about the metastatic workup, you said the CT scan showed tumor mass and liver metastasis only. So this is oligometastatic tumor. The oligometastatic tumor, only one area of metastasis, and there is a tumor, you remove it surgically. Even with the large area of metastasis, again, depending on the expertise, the available resources, primary surgery, if possible, feasible, and the expertise is available, then only you can do. Otherwise, the correct approach is that you give neoadjuvant chemotherapy and then do surgery after 3 or 4 cycles of chemotherapy. That is the ideal time of doing an interval debugging surgery. In some very, very restricted cases, you can do it after 6 cycles, but outcome is never very good. These patients almost inevitably recur within 6 months to a year. But I mean, it's better than doing nothing. Chemotherapy becomes the main treatment, becomes like a palliative treatment. Surgery is done, but I don't think this surgery will give her any additional benefit of survival.
Okay, sir. Sometimes we actually know the ideal situation, what should we do? But in the remote area, the peripheral the medical colleges where there are maximum patients, these patients are the lower socioeconomic condition, and they have sometimes the medical colleges doctors, and from their poor fund they have to pay for even after advanced imaging, either CT scan or MRI. In that situation, always they cannot maintain everything, and they advised for the neoadjuvant chemotherapy, but patient receives only 2 cycles, and she lost. And again, it came back after 3 months. In that situation, so what is the message from here? If this type of cases, they should not go for the surgery. They can go for the palliative chemotherapy or same schedule chemotherapy.
See, Shanawara, this is a very important question you asked.
Yeah.
I had a discussion with you people before as well.
Yes,
I think what you should be concentrating on is capacity building.
Yes,
so
sir.
If you have the capacity, if you build the capacity in the district areas, at least a small team who will be able to take on. It's a group of dedicated doctors, a surgeon, a gynecologist, a medical oncologist, everyone coming together with the radiologist and pathologist to build an oncology center who can actually take on these types of cases and operate. It's extremely heartening and sometimes disappointing that, of course, patients are poor, they cannot pay. So, of course, the government will have to provide for the resources, but not only resources, not only the money is important, is the availability of the human resource, the availability of the expertise. And that is capacity building. That will take 10, 15, 20 years time. But if you initiate now, definitely will reach there in the near future.
Dr. Shahana, is it possible that somebody goes from the institutions who are trained to these places and operates maybe once a month or once in 2-3 months? Because you have some expertise in Dhaka and bigger centers. So is that possible? Because if the patient can't afford to go there, can the doctor go to the patient?
Yes, ma'am. But we have around the 64 districts, and from that 64 districts, we are trying. There was no the ideal training in gyne-oncology, and now there is the fellowship in gyne-oncology, and we are trying. There are around that recognized the gynae oncology. They have completed their fellowship. That is, we have the 5 the fellow in gynae oncology, and there is huge fellow. They are getting training from gynae oncology, and in future, as you know, it is the policy maker who can make this. We are not the policy maker. We are just that trying. We are trying our best to make the best treatment, and we are trying to accustom the doctors in the medical colleges. And if we can try, we have to, as we are working in government hospital, and if we want to go, and there are 64 districts, and there are around 80 or 90 government medical colleges in that area, then how many doctors can go there, and who can do this? We are trying at several years ago, or 2 to 3 years ago. Sometimes we are in different areas. We have gone in different medical college, but now it is not always possible to go there, and always the patients are not available. Sometimes some patients in Dinajpur, that is in northern part of the Bangladesh, and sometimes patients in Chittagong, sometimes patients in Borishal, like Rajshahi, and it is not always feasible. Sometimes it is feasible, not it, but always it is not feasible.
Yeah, but Dr. Shahana, Bangladesh is doing so well on other fronts, like it's doing well in economic front, it's doing well financially. It's better than many countries, better than Pakistan, I think. So probably you all should influence your government to invest more in health. That's something I think, because you people are better on a lot of parameters. You'll have done very well, Bangladesh.
In
Yes, ma'am.
fact, we are trying to develop. We're trying to train this younger generation so that they will fight for the necessities they need to require. Government in hospitals in the periphery, we don't have that much of manpower at the moment, but that patient is there. So we, from the oncology club, trying to just make them sensitize them, so they can do as much as they can. Even they can ask advices from us. We're ready to give the advice. This is how we're trying to develop. Just in development process, I think it will take 2 years more to make this thing happen. Thank you very much for your suggestions. We'll certainly take it matters.
Yes, sir. I request our scientific secretary, Dr. AFM Kamaluddin Bhai, for comment regarding this question. Kamaluddin Bhai, please.
Yes, Shahana.
Yes, I request the Shalini ma'am and Joydeep Bhumik sir. They have, as you are in these sessions, and please comment on the suggestion of our sir and madam, please.
No, thanks, Shalini and Dr. Joydeep, for the wonderful suggestions. But the problem is, yes, somebody should move, either the patient or the doctor, because we don't have the resources. And as Shahana said, we are trying. But at the same time, this effort is also a part of that effort. We are trying to bring the cases to you people. And with 1, 2, 3 cases, I think they will learn how to manage it. And gradually, I think this knowledge dissemination will help to improve the situation. That's why I think what we are going to try.
Yeah, or maybe if that's not possible, the doctors in the hospitals like Dr. Snigdha and all could go for training, or at least go for some workshops, some cadaveric workshops.
Yeah, they are coming.
And yeah, so
they are actually coming
they can
to the
be
center.
trained. It'll take time, but training is possible if you're not able to go and reach them. I think these people should be trained at your center.
Yeah, Shalini, what I agree, but this is a later part regarding the quality of surgery. But what I understand, very primary, I mean, the selection of patient, assessment of patients, we are struggling at different level due to the lack of exposure.
But
so
I think here, in this particular case, this
is a different case. This is a different case. What I am telling, say, there are many situations we found, there the lack of the exposure. At the very beginning, they struggle. So this type of program is that, so that when they are facing say, there's a debate, shall we go for a CT or MRI? Is ultrasound enough? These small but very important things we are trying to clear up. And definitely we take your suggestion. The training there is no alternative of training. And we are happy that people like Joydeep is helping us to train our colleagues there. Already some of our colleagues was trained at their places. Don't worry, with this proposal, we will take it, that we will be knocking your door, your and Joydeep's door, to send some of our colleagues there even for training. Don't worry. We will
Yeah.
take the opportunity.
Sure, sure.
Okay.
Very, very welcome. It's extremely important. We have been
Yes, sir.
exchanging ideas and exchanging
Yes, sir.
our training program. You're very,
Yes.
very welcome.
Trying our best. Actually, we are trying our best. Just we are beginner of the session. We are beginner. That we have included all the medical colleges, and every alternate day we are arranging this tumor board. And in this tumor board, as Dr. Kamaluddin Bhai said, that they present their small, this simple case and how they should proceed. They are by this process, and they are getting training, and we are and in our line, our too many doctors are in gynae-oncology course. I think after they have passed their fellowship in gynae-oncology and they are in government job, and there is no post in the medical colleges, and government are trying for the making post in medical colleges so they can get posting to that medical college. So these patients will get help. And what Dr. Kamaluddin Bhai said, that Joydeep Bhomik sir, and we shall try our best to send some of our doctor to your center so we can get help from you, as you people are always helping us. Snigdha, please.
Most important thing is, again, the initiative that you have taken, that somebody has to start it, somebody has to begin it. And this congregation now that we are discussing, 120 people watching us, this is the most important part of the entire thing that you have started. I'm sure in the next few years, you will have many more doctors who are interested, getting trained, and giving better outcome for patients in Bangladesh.
Vijay Ahuja sir raised hand. Ahuja sir, please.
Dr. Ahuja has raised his hand. Yeah.
Yes. Ahuja sir, please.
Rauja is still muted.
Yeah.
Afuz, please unmute Ahuja sir and Dr. Zanna.
Hello.
Yes, sir.
Yeah, it was a very interesting discussion, and both the experts, even the case as well as the policies, I think I don't have anything to add. But coming back to the case, now this is for the benefit of our young trainees and postgraduates. You said that at the laparotomy now you could not proceed because you had extensive metastasis on the small gut and the large bowel. So the question is whether one approach is when you are not sure what you're going to find inside, you start off with a subumbilical incision, put your hand in, bring the bowel loops out and see if they're normal or not. If they have extensive small bowel or large bowel still can be managed, but if there's a lot of small bowel and mesenteric involvement, then you know that you cannot achieve cytoreduction. Then the question comes whether you should go ahead and do the surgery or just close and give second-line chemotherapy, because whatever you do is not going to help. Secondly, if there's a lot of peritoneal disease in the pelvis and you remove the uterus, the chances of vault infiltration and bleeding and quality of life going down is more. So this is an open question. I'm sure the experts will be able to highlight this also. So I thought this aspect should come out for our trainees. Thank you.
Thank you very much, sir. Dr. Jannat Jasmine, please. She also raised hand. Dr. Jannat Jasmine, please. Mahfuz, please unmute Dr. Jannat Jasmine. Dr. Jannat Jasmine, you unmute her.
Yeah. In the meanwhile, I think, yes, I agree with Dr.
Yes, sir.
Hello.
Yes,
Yes. Good evening. Hello.
yes, yes.
Yes. Thank you, ma'am. It's a very, very important and practical discussion. I think the problem is that we treat the patient frequently in underweight, so it does not like to help the patient. And till then, we trying for better option and development. So my appeal to your class through you, that sooner you will be more developed for betterment of complete surgery, I think. Thank you.
Thank you very much. Thank you, Dr. And Snigdha, please. Yes, sir. 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 Yes, sir
The histopathology report of the patient showed that in both ovaries there was papillary serous adenocarcinoma, which was high grade, and at omentum it was metastatic adenocarcinoma.
Next.
What
Thank
would you like to do at this point of time? You've given her 4 cycles of chemo. She did respond. And what would your adjuvant treatment be?
Yes, again they placed that patient in tumor board, and probably they received the same scheduled chemotherapy. I don't know. Snigdha, what you did?
The patient was then again placed to tumor board, and the decision was to give 3 cycle of adjuvant chemotherapy.
Okay.
So if we come back to a more hypothetical situation, that yes, this patient can afford to pay for a treatment, is what should be the ideal treatment at this point of time? So it can happen, even the best of the expertise, it can happen of the best of the resources, a lot of money. The same thing can happen, that initially it was inoperable, completed 6 cycles of chemotherapy, tried to operate and still it's inoperable. Then what to do? So if you have the resources, now bevacizumab is a drug which has been much hyped, but did not show any survival benefit over and above the standard treatment. But this is a small subset of patients where you couldn't do surgery, there's a residual disease, and bevacizumab has probably got a role to prolong her disease-free survival. Okay, you probably may not be able to increase her overall survival, but to give her a disease-free interval, bevacizumab can be tried for these patients.
Dr. Jaydeep?
Yes.
Yeah, have you used bevacizumab at the NACT setting? Because I've used it in some patients with massive ascites and a large volume, a large load of tumor load, and it did help bring down the ascites, and operability was good too, but you have to wait for 6 weeks maybe after BEV if you use BEV for NACT. So what is your experience with BEV and NACT?
The protocol we use at the moment, when the patients come to us and we decide that this is not for primary surgery, they will go for neoadjuvant chemotherapy. And if the patient cannot afford to pay for bevacizumab, they will have paclitaxel carboplatin for 3 cycles, response assessment and surgery at the interval setting. And we also try and promote HIPEC at that time. Now, if the patient can afford, the first 2 cycles of the neoadjuvant chemotherapy will be paclitaxel carboplatin and bevacizumab. We omit the bevacizumab in the 3rd cycle. And then bring them back for surgery. Now, we are collecting our data. It will be published in the future, whether this has really made any difference or not. But as a surgeon, when I'm seeing the patients, they are probably easier to operate compared to just paclitaxel.
Yeah.
Long-term survival, I'm not sure.
Not long-term survival. I'm talking about operability and resectability, and
yes.
especially the load of tumor load and the ascites does come down. I know I have experience with only 4 or 5 patients, but we need to see a larger data. Yeah.
We are collecting a data. We'll be publishing maybe in a year or two.
Do we have another case?
Yes. 3 more cases. Snigdha,
3 more cases?
Yes. Snigdha, please stop your screen share. Snigdha?
Thank you, madam. Yes.
Thank you, Snigdha.
Thank you, madam.
Thank you very much. Now, first, Dr. Tahmina. Dr. Tahmina, she is working in National Institute of Cancer Research and Hospital. Dr. Tahmina, please present your case. Go to the first slide. First slide, Tahmina. First slide, please. Proceed. Tahmina? Proceed.
Am I audible, madam?
Yes.
Is the slide visible, madam?
Yes.
Honorable Chairperson, respected domestic and foreign faculties, my respected teachers and learned audience, Assalamu alaikum. Welcome to this Tumor Board session. She is 34 years lady, para 1, underwent total abdominal hysterectomy due to fibroid uterus in 2016. Her histopathology report was low-grade endometrial stromal sarcoma. She was referred to National Institute of Cancer Research and Hospital, but did not attend. On February 2018, she attended our outpatient department with the complaints of rapidly growing lump and pain in lower abdomen. Her bowel and bladder habit was normal. She did not give any personal or family history of malignancy. On examination, her ECOG performance status was 0. All vital signs were within normal limit. Parabdominal examination revealed a huge mass about 25 into 20 centimeter with restricted mobility felt in lower abdomen and part of upper abdomen. The mass felt through the vault in paravaginal examination. Ultrasonogram of the whole abdomen revealed multiple complex abdominopelvic mass lesion in the with low-level internal echo. The largest one measures about 25 into 24 centimeter, and another one is 6.5 into 7.4 centimeters. The tumor markers levels were within normal limit. So, what will be the next treatment plan?
Before that,
Investigation. Yes, sorry,
Yes,
sorry.
madam.
yeah, before that, what could you have done in 2016? You had the report of low-grade endometrial stromal sarcoma. Go back to that first slide.
Yes, madam.
Yeah. So what could you have done at this point of time in 2016?
At 2016, the patient did not came to our hospital, madam.
No, but you got a report of low-grade endometrial stromal sarcoma, right?
Yes, we got the histopathology report and the patient was informed to attend our hospital, but the patient did not attend.
Okay.
When she came to our hospital, it was already late.
Yes. After 2 years, she attended here.
Okay. For the benefit of the audience, people who are from all over Bangladesh, or what could you have done if you had the report in 2016?
Yes.
She came to you in 2016 with this report, 34-year-old. Could you have done something at that point of time? It's for the audience. This is for the benefit of the audience.
Amina?
Yes, madam.
Please answer.
If the patient came to us in 2016, then as the patient presents with low-grade endometrial stromal sarcoma, the operation was appropriate for the patient. But I must want to further evaluate the patient's histopathology report by review, or immunohistochemistry may be performed to explain.
No, you've got a report of low-grade stromal sarcoma, right? So why do you want an immunohistochemistry? Can we do something simple at that point of time in 2016? Could we have done something?
Please.
So
would you please, madam, share your knowledge?
no, because it is an estrogen-dependent tumor, and we could have probably done ovaries, right? Removed her ovaries.
Yes.
Because it's an estrogen dependent, the ERPR receptor status is very high in these patients, and removal of the ovaries is indicated, maybe probably for that small group of patients who have not completed their family. Maybe after they complete the family, you need to remove it, but that's something that could have been done.
Yes, madam. But
at that point of time.
The patient came to us with already recurrence.
Amina.
No, I was just saying, what could any gynecologist have done at that point of time, anywhere in Bangladesh, if she had a report of low-grade stromal sarcoma and she's only had a TH? She's only had a TH.
Imaging,
could have removed the ovaries, right? Yes. Even at a second sitting.
Yeah.
Like we didn't have to wait for it to recur, right? Yes, because low-grade stromal tumors, the survival is very good, between 85 to 90% or 95%. Yes, so just removal of the ovaries would have been sufficient. We could have saved her. This is for any gynecologist. It's not just for oncologists. I mean, this is for any gynecologist.
Highly sensitive.
Yes.
Receptor. So the This is the recommended treatment. Yeah.
The ovaries could have been removed. So this is for everybody listening.
Yeah.
Yes,
And
madam.
the other important thing is that, see, this patient has come to you 2 years later, and she was unaware that she is actually suffering from some sort of cancer. So if she knew that it's important for her to have a regular follow-up, so you might have had picked it up earlier, a lot earlier than the 2 years. So if you had seen her, the first important thing is removal of the ovaries, and second important thing is to schedule up a follow-up appointment. Now the follow-up is only acceptable to the patient once she understands that she has got cancer and that cancer can recur. Earlier she comes to you, the better. So
Yes.
majority of the time we fail to communicate that to the patient. We give
Yeah.
her the treatment and sometimes we hide the diagnosis to the patient, thinking that patient should not know. But that actually becomes counterproductive because patient do not come for follow-up. And if we miss the early recurrence, then of course, if there's a late recurrence, there's not much you can do about it.
I think Dr. Kamaluddin wants to say something. Maybe he should be unmuted.
Shalini, my question to you is that there's a
Yes.
wonderful suggestion that you gave for
Right.
removal of the ovary. For some, say, at that time the patient was there, but family is not completed. So shall we go for suppression, ovarian suppression, or just as alternative of removing the ovary? That was my question there.
Yeah, maybe she can complete her family or try for a family and then remove it, because ultimately it is a estrogen dependent tumor, right?
No,
So
for example, say there is a story that she has one son and she wants to have one, something like that, or no baby. So you suggest that they complete the family, then remove the ovary.
yeah, because if you suppress the ovaries, she's not going to conceive, right? Because
Yep.
you're going to give something to suppress the ovaries using continuous letrozole or progestins, and then she will not be able to conceive also, right? So at least wait for 6 months. If there's no recurrence, 6 months to 1 year, maybe try, but I'm not very, because fertility preservation is an option in these young women. It is definitely an option. And maybe tumor markers for a high grade or low grade disease, if it's low grade disease, because now I think you do need tumor markers to differentiate between a low grade and a high grade disease. Morphology is also important. So
We have another case like this. We want to discuss after this case. We have another
Okay,
case.
okay.
Okay. Proceed. Tamina, proceed.
Yes, madam. Exploratory laparotomy was performed, followed by removal of the pelvic mass and omentectomy on March 2018.
Have you shown the CT report? Okay.
There was mass about 25 into 20 centimeter, densely adhering to the gut, momentum peritoneum, and also invaded the bladder. Another mass 6 to 8 centimeter impacted on the pouch of Douglas. Mass was dissected along with the removal of bladder tissue. Bladder and serous layer of the rectum were repaired. Omentectomy performed. It is the pictures of the specimen of multiloculated pelvic mass. The histopathology reports revealed the atypical mitosis 5 to 8 per high power field, areas of necrosis and hemorrhage, and pleomorphism, and the final histopathology report was endometrial stromal sarcoma high grade. The findings in the omentum was unremarkable.
So I think today tumor marker, the immunohistochemistry markers are important to distinguish the two.
Next
And
slide.
be sure, and you have to be very sure that it is low grade and not high grade that you're dealing with. Because high grade tumors definitely need more aggressive management. They recur faster, they recur much more, and mortality is also higher.
Yes, madam.
Yeah.
So the discrepancy can be overcome by doing the immunohistochemistry.
Answered, already answered. Next.
Thank you, madam. Immunohistochemistry was performed and the estrogen receptor and progesterone receptor was negative. So what will be the subsequent management? Sir.
Yes. So what did you all do? What is the
Yes,
subsequent
Dr.
management on high grade serous, high grade? Yes.
With us. We have one medical oncologist, Dr. Borin Goel. He is
Okay.
a consultant from Medical Oncology, Department of Medical Oncology from Rajiv Gandhi Cancer Research Institute. Dr. Borin Goel, please. Yes. Please
Yes.
unmute. Mahfuz, please unmute him. Dr. Borun Goel. Mahfuz? Mahfuz. Okay.
So first of all, thank you all, and sorry I have joined late. So just to summarize, I may see this is first site reduction or second site reduction of the patient, like this is recurrent setting or first setting.
Second, she's had one surgery before.
Okay. So as we have seen, this is high grade ESS, and like debulking have been done, technique have been done.
Yes.
There was some confusion on technique required or not for the second site reduction, but obviously if we are going for site reduction, we should remove that if possible. And now, what should be the subsequent management? So because patient is recurring, so we can give chemotherapy to this patient based on if we have given some in the first line of first site reduction or not. So whether she had received chemotherapy earlier after first site reduction or not?
No.
No, sir.
She didn't receive. Yeah.
We didn't receive
So if she didn't receive and this is recurrence, and now after site reduction, I would like to give chemotherapy to increase the PFS into the recurrence stage. So in this setting, usually paclitaxel and carboplatin based chemotherapy are given. And previously, there was some studies which have substantiated that we can give dip regime also, like we can add ifosfamide to paclitaxel and carboplatin, but nowadays it is well documented that only paclitaxel are sufficient. There is no need to add third drug that will increase side effect only, that will not increase PFS. So we can give 4 to 6 cycles of paclitaxel carboplatin. Some school of thought are that we can give ifosfamide adamycin based chemotherapy because of sarcomate component, but usually ESS high grade patients are chemo-wise usually treated like serious carcinoma.
Can I ask a question, Dr. Varun?
Yes, yes.
Yeah, is there any role of radiation in these patients? Because there are centers which do give chemoradiation and also give adjuvant chemotherapy. So is there any role of...
If in localized disease, maybe to decrease the local recurrence, but in advanced disease like this, in which even bladder wall was infected with the disease and it has been repaired, so there are very high risk of fistula formation. We go ahead with the radiation. So I don't think there is much role of radiation in the advanced setting. In the earlier setting, obviously it is like in the earlier stages, like stage 1.
Next.
The patient was placed to the multidisciplinary tumor board and chemotherapy with doxorubicin and ifosfamide was advised. During receiving chemotherapy, patient was evaluated after receiving 3 cycles of chemotherapy, and at that time the pelvic examination revealed a tongue-shaped angry-looking reddish pus about 4 into 5 centimeter in the wall. The CT scan of the whole abdomen revealed an ill-defined enhancing soft tissue density mass about 4 into 3.6 centimeter, recurrent or metastatic in the wall wall. Sir, what will be the next management in that case?
During chemo, it is this the recurrence during receiving her chemotherapy. After 3 cycles, yes, evaluation after 3 cycles.
Yes, we have seen that drug is high grade. Obviously, we know that primary refractory type and ifosfamide and adamycin based chemotherapy is not working for this patient. And I have told you that there is much evidence that we can try second line chemotherapy practice if patient PS allows us. If patient performance status is good, we can give doublet palliative chemotherapy. And about the if we can again surgically debulk this, I don't feel same. I don't think that now surgery should be done for this. only next line chemotherapy can be offered if patient performance is allowed.
Bhumik sir, please. Jodip sir.
Yeah, I agree. It's a sad situation that the tumor has progressed even during chemotherapy. Um, I may show my heroism by doing a surgery, but it will be futile. It will inevitably come back at some other place. It's a high-grade endometrial stromal sarcoma, and cat and mouse chase, as doctors, we're going to fail. So it's better not to give her any more trouble with surgery, just palliation, best supportive care. That's where I would distribute.
Yeah, I think with high-grade ESS, the progression-free survival is maybe just 7 to 11 months, and overall survival maybe 11 to 20 months or so. So it is an aggressive tumor known to have many recurrences, and the prognosis definitely is not as good, not even comparable to low-grade ESS. So that's something that we may have to even counsel and explain to the patients about
She had
at least
already
a
had a
high-grade.
partial mastectomy, bowel
Yeah.
resection. Going back into that area
Yeah.
surgically is not a very easy option. I mean, you can do pelvic exenteration. All these sort of things we can do, but
Maybe not in high-grade ESS because
absolutely.
yeah.
Quality of life will be horrible, and I cannot guarantee her survival even after exenteration.
Right.
So it's
Yes,
no point
I feel same. If we offer agitation to this patient, there will not be any survival benefit.
Yes, only
It
70.
may be very morbid procedure just to decrease quality of life.
Yes, but the patient, it was first operated in 2016, and it was the attended in gynecology department in 2018, and the surgery was done in 2018, and then 3-cycle chemotherapy at the end of 2018. Tamina, when the
Madam?
2018, yeah. So when
Yes.
the surgery done, second
Madam.
surgery,
Yes, madam. Second surgery was done in July 2018, madam.
yeah, so July, and the recurrence was during the chemotherapy when it was. Tamina?
Yes, madam. It is June 2018. The patient came to us for evaluation in the outpatient department after receiving 3 cycles of chemotherapy. And at that time, she was diagnosed as a recurrent case.
No.
What happened? Mhm.
When the second, the recurrence.
Yes,
Yeah,
madam.
chemotherapy. Yes.
In June 2018, madam.
Which
And
during
next second operation was performed in July 2018.
chemotherapy, the third cycle chemotherapy, when the patient was evaluated, after third cycle, when it was evaluated.
June 2018, madam, at the last of the June 2018. First operation was performed in our hospital in March 2018.
Okay.
After that, she received 3 cycles of chemotherapy, and at the last of June 2018, she was again diagnosed with recurrence.
Yes.
What did you do in July 2018? You said something?
Next, yeah.
The laparotomy was attempted on July 2018, but due to dense adhesion of the gut and urinary bladder with the anterior abdominal wall access to the abdominal cavity was not possible, and the mass was removed vaginally. It is the specimen of the pelvic mass that was removed operatively. And the histopathology reports shows negligible pleomorphism. Necrosis was absent, though the endometrial stromal cells arranged in the shapes. So the histopathology reports did not mention regarding the grade. The histopathology report only mentioned that it was endometrial stromal sarcoma.
But would you want to do the histopathology after chemotherapy again? Wouldn't that?
Yes.
Is that?
I don't need again and again histopathology because
I don't think it's
already high grade disease, and so what we will achieve. We just want to see.
And it is free of cost, so we do that. It is government hospital. Everything is done in government hospital.
There is no problem in doing. Obviously, whenever we are doing excision, some tumor is removing, we will do histopath, obviously. But treatment point of view, there is no need.
Okay, sir. Thank you, sir.
Ahuja sir raised hand.
Yeah, thank you. See, the question is, this patient is under treatment follow-up recurrence since 2016. And I have not seen a final ISC confirming high-grade lesion. I don't know whether we are really dealing with a high-grade ESS after 5 years who just still has disease limited to the abdomen and pelvis without any metastasis. And the last, whatever we saw, the tumor removed from the vagina, it's more in favor of a low-grade ESS.
Low grade.
And low-grade ESS would not respond to chemotherapy, and then it will have an indolent recurrence. So I don't think that we should be talking of high grade for this patient. We should do the IC. I think CD10 if negative, it's obvious it would be low grade. And then I think that management would change. I mean, we shouldn't be thinking of this thing. It will be mainly letrozole or something should come in, because 5 years and undifferent.
Not 5, 2 years. 2 years.
No, she's from 2016. She's on the same sort of a histology. 18.
No,
she
in
has a
18
relapse.
only. No, is she still alive?
Or some,
She's still
yeah,
alive.
I don't know if she's still alive.
Okay,
3,
she's
4
still
years.
alive.
No?
IC was
I
done.
don't-
IC was
She's still
again
alive.
high grade. It was IC. There is aggressive surgery was done during that time. That is the first sitting. That is in June 2000. There was no the visible disease.
No. What was the
First
ISC
surgery done?
markers in the second surgery, right?
Yes.
No,
What was
she's
the
on
ISC?
treatment since when?
And the
Since
marker only done estrogen receptor and progesterone receptor. Other markers were not evaluated.
Oh,
Oh,
okay.
it's done. Yeah.
Yeah.
So
But
like Dr.
in the first surgery
Ahuja's,
only it is high grade. There is obviously it will be high grade only. If first
no.
surgery,
First surgery was low grade. Yes, you
Okay.
came in late.
Okay,
Second
okay.
surgery they said high grade.
Okay.
Third surgery they're
see,
saying
in 3-4 years, it will not remain in a non-metastatic stage. It will
Right.
high-grade lesion would not have behaved like this.
yeah, looks
whatever
like
it
low
is.
grade. Looks
So
like
it's
low
most
grade.
probably a low-grade lesion.
Right.
So I think review and do ERPR, and that's I think.
But ERPR was very low, no? Less than 5%.
So I think just maybe the sample now you have a vaginal growth, a big one which came out. I don't know whether they have anything now. They can just review or give a trial of letrozole straight away,
Right.
rather than giving any high dose chemotherapy or anything.
My idea of not going for surgery was based on the fact it was a high grade. But now, I mean, if we are revisiting that diagnosis, and of course,
If it is low grade, how it is aggressively it metastasis? In
the
low,
low grade ESS will not respond to chemotherapy. So the treatment is surgery and hormone treatment. And again, you have to assess for resectability and give letrozole in the adjuvant setting.
Dr. Shahana, it didn't metastasize widely, right? Otherwise, there have been distant metastasis, there have been lung
do you
metastasis.
think the low grade is it feasible to metastasis? Aggressive metastasis in low grade? Do you think so?
No. It's not
Yes.
there, right? It is local.
In
Yes.
low grade only local recurrence will be there, but still if it was low grade within 3 months, I may say 2-3 months in the time span of 3 cycles, it should not again grow this much.
No, but the ovaries were not removed. Initial surgery, she had only a TAH and the
Yes.
ovaries were left behind. 2 years later,
No,
she came
like
back with
I'm
this
saying
big
that
mass.
in 2018 second cytoreduction was done, and after that the 3 cycle of IA based chemotherapy was given. Even after those, disease is increasing, and they have done again per vaginal excision. So within span of 2-3 months, if it was a low grade tumor, this should not be the growth rate. And
No. We've seen low grade tumors recur like this. They keep coming back with
Yeah,
a
the low
void
grade-
growth. They keep
but
coming
time
back with
duration
a
should be
low-grade
void
more.
growth.
Like low grade tumor usually recur back, but in the time duration of that recurrence is usually in maybe in years or maybe more than 6 months, not within 2-3 months.
But low-grade lesions, do they generally don't have the same response to chemotherapy as
Yeah,
high-grade
they
lesions?
don't respond to
So
chemotherapy.
you
For
may
those
have
only
a
farmers
variable
get
response to low-grade tumors. So you cannot say that because it recurs fast, it's not low-grade. So it should
Because
be
we've
low-grade.
had cases of low grade recurring just like this, vault recurrences coming back in 3 months, 6 months, and they're living for many years, 10 years,
Yeah.
12 years.
Low grade patient usually not that symptomatic.
They have tremendous ability to invade the vessels, big vessels. I mean, the pelvic vessels, from tumor traumas even. We had a case recently where it extended through the ovarian vein into the renal vein, from the renal vein into the IVC and right up to the atrium.
Was that an intravenous leiomyomatosis rather than an endometrial stromal? No?
Low grade ESS.
Okay.
Sushil Kumar Giri sir. Sir, do you like to comment? Giri sir, please.
Giri sir is there?
Yes. Giri sir, please. Oh, probably he was here. And he still is here. Giri sir, please. Okay, Tamina, proceed. Next.
He's unable to unmute, I think, Dr. Giri.
Dr. Yeah. Mahfuz, please unmute Dr. S.K. Giri.
Okay, ma'am.
Unmuted.
Good evening, everybody. It is a really interesting case. So from very beginning, it should have been review of the slide could have been done, and IC could have been done from very beginning of the when there is a low grade, then it comes a high grade, as Dr. Vijay has told rightly. So you could have done IC to rule out whether we are dealing with high grade or low grade, and perhaps as everybody suggested, it is the most probably low grade because there is no metastasis. It is a localized disease, recurrent localized disease, which is common in low grade. So I don't think any chemotherapy will help. Perhaps at this point, either we could have gone for surgery now, because low grade the treatment of choice is surgery now with recurrence, or else we should go for the letrozole as everybody suggested.
So maybe this time, Dr. Giri, they should put ERPR receptors.
Yeah.
And if they are positive, put them long-term letrozole.
Yeah, that is
Yes,
the only solution.
but even after a high grade and due to the recurrence within 3 months, we also used the letrozole to these patients.
Most probably the recurrence was not recurrence was in the, most probably the ovaries might have got this disease. Disease is not the so ovaries might have the disease has spread to the ovary, and because it is a estrogen dependent tumor, and the recurrence is in the ovaries now, most probably. I don't know from where
the
it is.
ovaries were removed later, right? In the second surgery, ovaries were removed. No.
The second the first was low grade, then the second surgery the tumor was removed.
Ovaries must have been removed at that time.
The tumor was in the ovary, most probably.
Yeah.
Is not it? Most probably it was in the
Yeah,
ovary.
but still, even after ovaries are removed, you can still have the tumors having ERPR receptors, right? So we can still give them letrozole.
Yeah, that is the reason. And the vaginal recurrence was given because we have given chemotherapy, which is not responded. The chemotherapy was not responsive at all. Yes. That's why there was a recurrence at all. Most probably you could have given the letrozole here by doing all these things.
Yes. We have given letrozole and patient receives letrozole for 6 months. Next. Tamina, next.
At that point, what will be the subsequent management, sir? The patient has received 3 cycles of chemotherapy with doxorubicin and ifosfamide, and again operated for that recurrence. So what will be the subsequent management now, sir?
Next.
The patient received another 3 cycles of chemotherapy with the same schedule up to October 2018. And the patient was advised for regular follow-up. And on November 2018, patient again visited in the outpatient department with a complaints of parvaginal bleeding. And on parvaginal examination, a polypoid mass about 2.2 into 2.5 centimeter identified in the bone.
This is typical of low-grade ESS.
Yes, madam.
Yeah.
We advised a MRI of full abdomen revealed ill-defined heterogeneously enhanced soft tissue signal intensity lesion 3.5 into 1.6 into 4.8 centimeter in the right advential region, and omentum thickened and nodular, and few submesenteric lymph nodes. So how the patient will be managed now, madam?
I think you'll have to get the ERPR receptors done. on the previous mass itself and then put her on long-term letrozole. They can take it for years.
ERPR done again, but yes, ERPR negative by still we had
Clinically, it's behaving like a low-grade ESS, isn't it?
Yeah.
It's clinically behaving like a low-grade ESS.
next. Next.
We again attempted laparotomy in 2018, and there was addition to radiolarysis can be done, and removal of the soft tissue mass from the abdomen to the abdominal root, and residual omental tissue also removed, and vaginal vault excision done per vaginally. And the histopathology reports revealed endometrial stromal sarcoma, which is recurrence, and it was high grade. Mentioned in the final histopathology report, there was extensive pleomorphism and frequent mitosis. And the omental tissue was unremarkable, and tissue from adnexia size, it was also unremarkable.
It's mutating like the coronavirus.
Yes, better. Madam, now the patient is operated for subsequent recurrence, and what will be the adjuvant treatment in this patient or subsequent management, madam? Sir?
Dr. Varun will tell us.
As I told you earlier that obviously we have removed the main disease bulk and this is still high grade only. There is no ERPR positivity. So obviously in view of ERPR negative status and high grade, even letrozole, we may give as a placebo, but I don't feel that it will work. So if patient PS allows, we can try one more set of chemotherapy in the form of paclitaxel carboplatin. We may add, go ahead for some agonistic markers like MSI, next generation sequencing. If we may found some another targetable lesions or targetable mutations. We may add those if chemo is still not working. First, coining this is chemo refractory, we can try one more set of chemotherapy in the form of paclitaxel carboplatin. I don't feel that on the progression on ifosfamide and adriamycin, we have continued the same set of treatment. I feel that same set of treatment is not of much benefit of that time. That time also only we can change over the chemo regime. Otherwise, we can go ahead for agnostic markers.
What about targeted treatments? Because sarcomas, like for GIST and other things you have, because sarcomas are solid tumors and there are targets available, right?
Yes, for ESS also, there is some data regarding pazopanib use. We have given in our patients and that drug have worked in those patients. As I told you, we can go ahead for this foundation 1 test or next generation sequencing test to see if there are any other targetable mutation. We may add bevacizumab to our chemo regime if we are going ahead with the chemo regime, but single agent bevacizumab will not work.
Sahana, Dr. Ahuja raised his hand. Sahana.
Ahuja, sir, please.
See, the most of the recurrences are happening around the vault only. Whether there will be any role of brachytherapy in this case, because again and again, what was the final momentum? I don't know, but most of the relapses are around the vault. So I think brachytherapy could be added because now we are talking of a palliative situation. So brachytherapy would help prevent a local or better vaginal control, because chemotherapies we have seen the control is not so good. So an alternative modality, known modality which can control disease, because the low-grade ESS also radiotherapy is effective, and even in vault relapses because of high-grade lesions also for symptomatic control we give radiation. So I think brachytherapy would have a role.
I also will concur with your view. Like we can give option of radiotherapy, but we have to see there are high chances of fistula formation, mainly this rectovesical fistula formation, because we have already during surgery have repaired those, and there was infiltration of the disease there. If we have done exentration, then radiation will be very well have place for the management of this patient. But still, we can offer radiation because we don't have much other options.
Yeah, brachytherapy, the risk of fistula would be much less. I'm not talking of radical pelvic radiation. talking of brachytherapy. So that would be an option.
I totally agree with Dr. Ahuja that when we are thinking of brachytherapy, the risk will be much less because we are not thinking of EBRT. And in this type of situation, definitely that could be a better option because it is totally chemorefractory. Rather chasing, I think we can go for some local intervention.
So aggressive and the high grade endometrial stroma sarcoma, it should be aggressively treated by chemotherapy and also the radiation, brachytherapy. Yeah.
But like disease is not just on vaginal vault or just on cervix, just on uterine, like it is in ovary also. It has in the whole pelvis. I don't know what like my radiation. I will refer to my radiation colleague also. Obviously, I will take his or her opinion also. But just brachytherapy, I don't feel is of much use.
And even if you are doing the brachytherapy, the bowel is inevitably stuck to the wall of the vagina. So the risk of bowel injury with an intact cervix, intact uterus, compared to a post-operative brachytherapy, of course, is more. Standard surgery, not much of like we give brachytherapy for endometrial cancer. But in those situations, even if after surgery the bowel is not at much risk, but given this patient where this is a third surgery she had undergone, and then the risk of bowel adhesion, bowel mobility is something we have to be very carefully consider before giving radiotherapy. Radiotherapy is definitely, I mean, one of my radiotherapy colleagues was saying you can treat any cancer with chemotherapy, with radiotherapy, because radiation will kill all cancers. But it's a tolerance that is more important. Whether that patient, that area can tolerate that amount of radiation, that is more important. So that's a matter of judgment, I think.
Dr. Shahana, can this patient afford anything?
Yes.
Then we can look at targeted.
Please go ahead. Ramina.
The patient was placed to the multidisciplinary tumor board and patient received 25 fraction of EBRT and 2 insertion of brachytherapy up to April 2019. But unfortunately, the patient developed multiple intercutaneous fistula on December 2020. She underwent exploratory laparotomy for the closure of the multiple fistula and dissection of the loop containing multiple fistula done along with defunctioning end ileostomy.
But she was well from April 2019 to
now
December
she's
2020. Yeah, it is around 2 years.
Yes, madam.
Yes.
So now the patient needs not only treatment but also care. He is a patient of palliative care. Thank you, madam. Thank you all for patient sharing, and thank you to madam for giving me the opportunity to present this case in the platform of Oncology Club. Thank you, madam. Thank you all.
Now the patient is still alive.
Okay. Yeah. Must be ESS only then. Low grade, I mean, low grade ESS.
Yes, madam. Thank you.
Bowel complications always happen a little later. It doesn't happen immediately. It happens a few years later. And it can actually be very, very, very painful, distressing. Multiple intracutaneous fistula is a serious problem. Quality of life is very poor.
Yes, sir. But
I think the lesson.
Detrozole now. Can we advise her detrozole again?
Empirically.
Till now she hadn't received letrozole or had received that.
She stopped. We advised her letrozole and she received for 6 months. But after that she discontinued that.
By herself without any progression.
They have gone several centers from.
Most of the centers have not advised for in view of high grade ESS. So for that reason.
Also the neighboring country, yes. Can we advise letrozole again, huh?
I don't feel it may be just a placebo.
Yes, placebo, for placebo.
Yeah.
Okay, thank you very much.
Osteoporosis after that.
Sir, please.
With letrozole, she's risking osteoporosis, isn't it?
Yes. Okay, thank you, sir. Please stop your screen sharing.
Thank you, madam. Yes, ma'am.
Yes, now I request Dr. Dr. Sylvia Sutana. Dr. Sylvia, please present your case.
After this is another case, Dr. Shahana?
Yes, ma'am.
Let them.
Okay, okay. Give me a minute. Yeah, please. Sylvia, please share your screen. We'll stop after this case. Okay. Sylvia. Proceed. Sylvia, please proceed.
Am I audible?
Yes, you are. Please proceed.
Okay. Foreign faculties, learned audience of home and abroad, very good evening to you all. I am Dr. Sylvia Hussain, Assistant Registrar of Gynecological Oncology Department of National Institute of Cancer Research and Hospital, going to present my case.
Proceed.
Age 30 years old, para 1, normotensive, non-diabetic, housewife of low socioeconomic condition, attended outpatient department of National Institute of Cancer Research and Hospital on February 2021 as a known case of low-grade endometrial stromal sarcoma with irregular parvaginal bleeding for last 6 months. She had history of polypectomy at her 20 years of age in 2011, but there is no histopathology report. In 2013, again, endometrial polypectomy done in local clinic, and histopathology report was low-grade endometrial stromal sarcoma. Review of the slide report was done, and the report was same, that is low-grade endometrial stromal sarcoma. Patient was referred to the National Institute of Cancer Research and Hospital, but patient did not come. Later, she conceived by ovulation-inducing drug due to subfertility and delivered by lower uterine cesarean section in 2016. In August 2020, she again had endometrial polypectomy followed by DNC due to irregular parvaginal bleeding. At this time, her histopathology report was myomatous polyp. Following polypectomy, irregular parvaginal bleeding persisted for the last 6 months, and the patient was referred to our hospital on February 2021. On evaluation, regarding menstrual history, her menarche was at 13 years of age. Her menstrual period and menstrual cycle was like polycystic ovarian syndrome, that is oligomenorrhea, which persists for 1 to 2 days and after 2 to 3 months interval. For the last 6 months, it's irregular, scanty in amount, and red in color. Regarding her obstetric history, she is married for 10 years, para 1, delivered by cesarean section, and she had history of taking ovulation-inducing drug, that is letrozole, due to subfertility in 3 courses. Her age of her last child is 5 years. She gave no history of taking hormonal treatment for this irregular parvaginal bleeding. We found patient was mildly anemic, low lymphadenopathy, and her other vital parameters were normal. Per abdominal examination was revealed nothing abnormality. Per vaginal examination, cervix was apparently healthy looking on speculum examination. On bimanual examination, uterus was normal in size, inverted, all fornixes were free. Her TVS report with color Doppler revealed slightly thickened endometrium, that is 14 millimeter, with an endometrial polyp that is 2 into 1.38 centimeter. Her other routine investigation was normal. On March 2021 at our hospital, we have done polypectomy followed by fractional curettage. and her histopathology report revealed endometrial polyp, and endocervical curettage report was chronic cervicitis. After 2 months of this polypectomy and fractional curettage, patient again developed irregular parvaginal bleeding, and we have done again TVS with color Doppler on 25th May, and it revealed endometrial polyp which increased in size. Previously, which was 2 into 1.5 centimeter, now it becomes 3.3 into 1.6 centimeter. Now, patient, there are some questions. What is the cause of this recurrent endometrial polyp?
So, I just want to ask one thing, whether we have seen any dysplasia or something, high grade hyperplasia in this polyp, or dysplasia, or
No.
just a simple polyp?
Just simple.
Just simple polyp.
Normally, once these patients develop polyps, they have a tendency to develop polyps. We do not know what is it in the patient that causes recurrent polyps, but this is really several times that she has developed endometrial polyps. But there are recurrent polyps are known to occur, but she initially did have a low-grade stromal sarcoma, but maybe in these polyps, she's not had any evidence of malignancy, right?
Yeah. Is there any chance of recurrence of low-grade stromal tumor after about 8 years? Because
yes.
the last one was on 2013.
Yeah. 10 years later, 15 years later, they can still recur.
They can recur.
Endometrial polyps are known to be recurrent. I mean, they can come back, especially in young women. They keep on coming back, and you just excise or you give them hormonal suppression and like inserting a myelinate system will sometimes help.
And even low-grade sarcoma, Dr. Homik, even low-grade stromal sarcoma can recur up to 8 years, 10 years, 15 years.
Low-grade ESS is again can recur many years after the initial treatment. And polyp can also recur. So every time you have to go in, do histoscopy, take the polyp out, and subject it for histopathological examination.
Right.
If it's a simple polyp, nothing more needs to be done except for you can insert a myelinate system. Or if it's a low-grade stromal sarcoma, you can then offer her more definitive management.
As we have done the polypectomy just in March, and now the size of the polyp is again recurring, this polyp, is it the histoscopic evaluation will be safe for her as we done it blindly previously?
Should be doing histoscopy, yes. Histoscopy is safe.
Okay. Now patient actually wants to conceive again. And so what will be our next management plan actually?
She can go ahead and conceive.
Yeah, she can conceive. I don't think any problem.
Before that, as there is a polyp about 3 to 1.6, so we have to remove it, isn't it?
Yes, after removing that only.
Yeah, you can take the help of a reproductive endocrinologist, reproductive gynecologist, or somebody who's into ART. Okay. Instead of you managing it, please send her to a specialist for fertility reasons, like for conception and ART and other things. I think she's better managed by reproductive specialists than oncologists.
Okay. Thank you, madam.
Okay. So the message,
after conception, after her complete of his family, if she wants to conceive him, if she conceives and after completion of family, should she go for the hysterectomy and salpingo-oophorectomy?
Not essentially. Actually, endometrial polyp is a very innocuous condition. It can keep on coming back. It can manage with the myelinate system more efficiently than a hysterectomy.
Sir, she had endometrial stromal sarcoma.
But she didn't recur, no? She didn't recur for so many years.
But one point is that she was anemic also because of this again and again recurrent bleeding. So for that point, we may offer after completion of chemo, we may offer hysterectomy.
Not only that, After completion of family, her endometrial stromal sarcoma, low-grade sarcoma, it may recur. And for that reason, should we not go for the completion surgery? That is hysterectomy and salpingo-oophorectomy?
Madam,
not
it's
for
a
the
stage 1A only, right? It's not gone, it's less than 5 centimeters, not, it looks like a very early stage low-grade stromal sarcoma, right? So if she recurs, then you go ahead. Why do you want to do it now? Why do you want to offer a hysterectomy now?
See, doing a hysterectomy is a very easy thing. I mean, 1 or 2 hour operation is done. But what happens to the woman for the rest of her life, something we'd never look at.
Yeah, there is, at least in this patient.
Yeah. So a young woman deserves to be, feel like a woman for the rest of her life. And so we should not be depriving her of that just because we suspect that there could be a recurrence. We can keep her under close observation. If there's a recurrence, of course, we treat her accordingly. The chances of recurrence are there. So is the chance of having a street-side accident. So I'm not barring her to go out of this house to go for shopping. So why should I order for?
Ahuja sir, please.
Yes, the thing is, she had a low-grade endometrial sarcoma in a polyp, and you have a recurrent polyp. So obviously, you'll take out the polyp to rule out any recurrent malignancy. If it is negative, you go ahead. But I would still be keeping a history of sarcoma before in view. I would still advise an MRI of the uterus to be sure there is nothing in the myometrium residual thing before advising any fertility. I mean, for any malignancy, you have to be 100% sure there is no persistent disease before you advise any further pregnancy or fertility management. So I would add an MRI before we do a fertility.
In fact, a complete metastatic workup.
Yeah, if obviously we are dealing with the lesion there, at least an MRI, as I said.
Okay, sir. Thank you, sir.
Another person raised hand, that is Galaxy S1. Mahpus, please. Okay. Galaxy S1, please. Oh, Dr. Rupender Shekhar ma'am is with us. Ma'am, please comment on this case. Dr. Rupender Shekhar ma'am. Dr. Rupender ma'am. Ma'am, Dr. Rupender ma'am. Please unmute. Mahfuz. Please unmute Dr. Rupender Shekhar. Yes.
She's my only comment on this is that she's unlikely to conceive herself. She will definitely require assisted reproductive techniques to conceive, because even if it is a polyp, it is definitely an unhealthy endometrium. So her chances of being able to conceive herself are quite less.
So thank you, ma'am. We go for the another case.
Short.
Yes. Thank you, Dr. Sylvia. Now I request Dr. Farhana Haq to present your case. Dr. Farhana Haq, please.
Assalamu alaikum.
Share your screen, Farhana.
Am I audible, madam?
Yes.
Assalamu alaikum, and welcome you all to our last case presentation. Mrs. X, 41 years old, diabetic, hypothyroid, hypertensive, para 2 living 2, consulted to a gynecologist with a complaint of excessive pervaginal discharge for 3 months, lower abdominal pain for 2 months. Her age of menarche at for 12 years, age at marriage at 25 years, and delivery of first child at 28 years. She took oral pill for 2 years. She had no history of irregular menstrual cycle or postcoital bleeding. She had no history of ovarian, colon, and breast cancer. On examination, her ECOG score was 0. She was obese, mildly anemic, and all other vitals were normal. Her abdominal examination revealed nothing abnormality. On pelvic examination, there was a cauliflower-like growth replaced the cervix, which was 6 into 6 centimeter. All fornices and upper one-third of anterior vaginal wall was involved. Left parametrium involved, but right one was free, and the rectal mucosa was free. Her HPR histopathology report revealed well-differentiated papillary adenocarcinoma. So clinically, this is a case of the carcinoma cervix stage 2B. And she was evaluated by various investigation. Our ultrasonography of whole abdomen revealed there was lobulated hyperechoic area, 6.5 into 5 centimeter at cervical region, and the multiple hyperechoic area in pelvis, 2.7 into 2.5 centimeter, and her pelvic calyceal system was not dilated. And her CT scan of whole abdomen revealed there was bulky with uterus with cervical mass 5 into 5.5 into 5.8 centimeter with extension into upper one-third of vagina, no parametrial extension. And interestingly, there was a bilateral complex solid cystic adnexal mass, right one measuring about 7.6 into 9 into 8.5 centimeter, and left one measuring about 7 into 5.5 into 5.5 centimeter, adherent to adjacent bowel and anterior abdominal wall. There is peritoneal thickening at infraumbilical region, and there is multiple para-aortic, bilateral common iliac, internal iliac, and left external iliac lymphadenopathy were present. And her chest X-ray and chest CT scan were normal. And her CA 125 was 330 unit per ml, and other parameters were normal. So radiologically, and finally, she was diagnosed as a case of carcinoma cervix stage 3 C1 with bilateral ovarian mass. So the question, there are some questions. The first question, what are the other tumor markers need to be done?
Is it a stage 3C or is it a stage 2A2 with bilateral ovarian tumor? I have question.
Madam, radiologically, there was paraortic lymph node involvement.
No, yes. So is this paraortic lymph node from the ovary or is from the cervix?
Madam, the question will come next.
So what will be the next stage?
The way this tumor is behaving,
Yeah.
the first, we need to make we need to confirm whether this is the primary is the cervix or the primary is the endometrium. Adenocarcinoma of the endometrium can protrude to the cervix. We have taken a biopsy from the cervix, and it can come back as adenocarcinoma of the cervix.
But it is a cauliflower growth in the cervix.
Yes, it can.
Yes,
So
Dr. Jaideep, unlikely to have such a large growth in the cervix to be an extension of an endometrial cancer.
I mean, the way this is behaving, see, it has already gone to the ovaries. It has already gone to the paraortic.
No, the ovaries, you can have metastasis from adenocarcinoma cervix to the ovary, right? 10% of them, 7 to 10%.
Positively that yes, it is a cervical tumor. That the immunohistochemistry and the MRI, I would prefer to do an MRI for her to see the epicenter of the disease on the MRI, and also look at the immunohistochemistry, the P16, all the markers should be done to make sure that this is a cervical primary, not something else. And the entire management plan will be based on that only. So it is very important to identify whether the tumor histological origin of the tumor. If it is cervical tumor, which is with possible metastasis to the in the parietic region, then first of all I have to confirm it has metastasized, not just a reactive node. So parietic nodal biopsy should be done because the treatment will be chemoradiation, and it should be an extended field right up to the parietic region.
Can it not be dual malignancy?
How big is the ovarian mass?
Yes, it is size. Size of ovarian mass.
Size of ovarian mass, madam. Right one measuring about 7.6 into 9.4 into 8.5 centimeter, and left one about 7 into 5.5.
So with these big masses, I don't think we can give
No,
chemoradiation, right? We'll
yes,
have to
sorry,
address
yes.
these masses.
Yeah.
So it is more looking like synchronous malignancy. It is not looking like
Yeah.
metastatic, because metastatic wise, these adnexal masses are large, like 9.4 into 8.5 centimeter.
You have to separately biopsy them as well.
Yes.
I feel we can go ahead with the ovarian laparoscopy in this case or not. What's the surgeon's comment on that?
Is involved.
Can you go for laparoscopy, sir?
No. But if it is metastatic from the cervix, why would
Such there is no clear cut. According to me, like we can go ahead with P16. It's okay, but it may be synchronous malignancy. Histopathologically, I don't feel is there any clear cut marker we can say that this is synchronous or metastatic. But clinically looking like synchronous malignancy, because adnexal masses are even bigger than the cervical region.
Yeah.
Yes, cervical cancer can come to the ovary, and the small series we have, the outcome is extremely poor. They do not survive beyond several months because they are very, very aggressive and bad disease. So yes, it's very important that we come to a proper diagnosis, whether it's the ovary is a primary ovarian tumor. So you can do a biopsy from the ovary and review the histology. I mean, there are subtle ways we try and differentiate. One is the P16 marker. Also, we also look for case for the histopathologist, but from our point of view, I think I would do a biopsy from the ovary and biopsy from the parietic nodes to have a complete picture about what we are actually dealing with before we decide on any treatment.
If we say, can we not go for the laparoscopy for these patients? That is adenocarcinoma. If it is carcinoma cervix and it is adenocarcinoma, as we know in adenocarcinoma and age is only 40, she is in this young age. If
the parametrium is involved.
No, parametrium, yeah, it's in CT scan. The parametrium is not
CT scan wise there is not involved, but clinically it was left side involved, right side not involved.
Not involved.
So one more way to manage it. We can start with some neoadjuvant chemo, and for post CSEC we can reevaluate, and after that we can go ahead for ovarian laparoscopy. I personally feel, if possible, upfront surgery followed by chemo should be given to this patient. Otherwise, neoadjuvant followed by, there is no role of radiation for this patient.
No, again, establish a diagnosis. That's stressing on the diagnosis. First of all, biopsy from the cervix needs to be reviewed, but there should be a repeat biopsy from the ovary to see whether it's a synchronous or something different, and also the parietic nodes, because the parietic node, whether it's coming from the ovary, whether it's coming from the cervix, or it's just a reactive node, we do not know. So the entire treatment, entire planning will depend on that. And yes, if it's an ovarian primary, if it's then of course surgery will be the primary treatment. You have to be very careful in handling the parametrium, because if the parametrium is involved, then you may need to reimplant the ureter on that side. So these are the things.
Parametrium is not involved.
CT scan is not a good way to identify the parametrium.
She was advised for CT, chest and abdomen. For that reason, can we not go for the MRI? And
MRI is better, but again, a clinical judgment of the parametrium.
Parametrium is free, and it is the carcinoma cervix confirmed by ISC. In that case,
with if the parametrium is free, carcinoma cervix is confirmed, then again, it depends on what is happening to the ovary. If the ovaries are involved with the cervical primary, then there's a different ballgame. If there's a different primary ovarian cancer, then of course a different ballgame. So that is also very important to identify before we plan any treatment for it.
We have the radiation oncologist, Dr. Kamaluddin Bhai, please, your comment, Kamaluddin Bhai. Dr. F.M. Kamaluddin.
Yes, Sahana.
Yes, your comment, please.
So cervix is a patient for radiation oncologist, but not adenocarcinoma. When it is adeno, we are more in favor of surgery because the very old trial, Antony, have shown that the surgery is doing far better than radiation in adeno. So if it is adeno, I think even in radiation oncologist, if possible, I will go for surgery. Dr. Ahuza raised his hand.
But sir, I think, but in present day, I think adenocarcinoma and squamous cell both respond to radiotherapy, right? I think
that's true. That's true. That's true, Shalini. But you know, there is two school of thought, and the Japanese. If you look at the Japanese, they don't at all go for radiation for adeno. We go for radiation, but you know, this is such a. I mean, when there is a debate like this, and if it is a adeno, they go for we can go for radiation. It responds, but response is poorer than squamous in adeno in this cervical
response.
Cancer. Yes, Joydeep, any comment?
Yes, I fully agree. I mean, the metastasis to the ovary from cervix is a very, very bad outcome. I mean,
no, Dr. Jaideep, forget about metastasis to cervix, to ovaries. We're just talking about adenocarcinoma versus squamous cell carcinoma and response to radiation.
Previously, we used surgery for them, but we have stopped doing it. I mean, if there is a residual disease, we can go back and do a surgery for these patients, but there is not very convincing evidence that surgery is better. I mean, almost inevitably they will need radiation again, I mean, as an adjuvant setting, and there's dual complications after surgery and after radiotherapy. So we have refrained from doing a primary, even for advanced, even for stage 1B, 2 large tumor. We prefer to go for chemoradiation first. We prefer not to do dual treatment.
How's sir, please?
Yeah, I agree with most of what Dr. Joydeep has said, that we have to be sure about the ovarian pathology. Cervical and endometrial primary biopsy is obvious, but ovary has to be ruled out. Now the question is whether we do an image-guided biopsy or is there a scope of laparoscopy, because the masses are borderline. If we can, even if it is not, adherent or anything, they can be just excised, because we have a locally advanced tumor in the pelvis. We are not going to touch that, but we'll be sure about the ovarian primary in this case. Dr. Jaideep said, MRI is a better evaluator than a CT scan. So clinical exam and MRI both should show negative for parametrial involvement. But she has an upper third vaginal involvement also, or something like that, what I recollect. So it's locally advanced disease. Regarding the role of surgery, primary or radiation, the first determinant of the modality is the stage of the disease, and then comes the histology. So if it is a locally advanced, irrespective of stage, you have to go ahead with radiation therapy. But in this case, if the ovaries come positive for malignancy, then there would be a role of neoadjuvant chemotherapy, and then give see the response, and then see whether surgery is feasible or palliative RT to the pelvis.
So Shahana,
according to me also, like we should start with neoadjuvant chemotherapy followed by surgical evaluation.
After the biopsy reports of the ovary and
we can go ahead with the ovarian biopsy, obviously just to ascertain same histopath and whether we can by any means we can confirm that it is synchronous or metastatic malignancy.
Is it usual without ascites, the bilateral ovarian tumor? This is ovarian, it's unusual. No ascites.
It may happen. Or as a C75 also not too much, like it is around 300 only.
Yes.
Okay. May I make one comment here?
Yes.
Yeah, Shalini and Joydeep, I intentionally, being a radiation oncologist, put up the issue of surgery in adeno because, this is an issue that had been going on, not on this special case. This is not a case to, I don't know, any surgery is possible. It's such a locally advanced disease, what Dr. Ahuja was telling. But I was quite interested to know about a very early stage, if it is a operable case,
Yes.
borderline, both operation and radiation is feasible, the borderline situation. If it is an adeno, what you people prefer? Going for surgery or radiation? Dr. Joydeep.
In this age, 40 years, young age. Yeah.
Not this case. This age, it is a classically
Yes.
operable, and we can go for both the modality, say
Then
one
we'll go for surgery. As surgeons, we will go for surgery, sir.
What we have to make sure that the patient doesn't go through dual treatment. That is
Yeah.
something kind of about. Fortunately, with our series at Tata Medical Center, 69%, we thought they are early disease. We did all these tests and found out that this is early disease we can operate. 69% patients had to have adjuvant radiotherapy.
Yes.
And really, over the last 10 years, I was so in favor of doing surgery, and now I've realized that even if you are doing surgery, there's the criteria, they are matching for adjuvant chemotherapy, adjuvant radiotherapy, and they are ending with dual treatment and much more complications compared to a single treatment. Only recently we had a 25-year-old patient, a young patient, there is a fertility. We're initially thinking of doing a trachelectomy for her, but the size of the tumor was just little above 2 centimeters. So we did a radical hysterectomy. Of course, we do lymph node dissection first, make sure the lymph nodes are negative. And then when the final histopathology came, the LVSI was positive. The infiltration is more than half of the cervix. And so she needed radiotherapy again. So even if in young patients, we do radical surgery, even suspected early cases, they all end up having radiotherapy, and we are just increasing their morbidity by doing dual treatment.
No, Dr. Jaydeep, we are talking about a situation in which she's amenable to surgery. So we do surgery only after a thorough evaluation with our imaging studies, right? Only then we decide that if there are no lymph nodes, no LVSI, a stromal invasion is not there, the size of the tumor is less than 4 centimeters, and we would prefer surgery, right? After you would still do surgery.
Surgery should be for non-bulky tumor only, like less than 4 centimeters. As Madam have told that it should be for 1B, 1A only, not for 1B.
No, 1B2, 1B2.
Dr. Kamal, question was in adenocarcinoma. Sir, Joydeep sir, in case of adenocarcinoma.
So our management plan doesn't now
Same
change.
principle.
Will you add, according to guidelines, there is no different guidelines for adeno versus squamous.
Yes.
Like we usually follow same guidelines.
1B3, they should always go for chemoradiation. 1B1, 1B2, yes, we do surgery.
Surgery.
Yeah, from radiation oncology point of view, we treat them with chemoradiotherapy radically, but most of the outcome is a bit poorer in adeno compared to squamous. That is what we have seen. There are many series on that. I intentionally pinched up the issue of going for surgery in adeno because I wanted to hear what is happening in AIMS and Tata.
No, we don't. We treat them as the same. Yes, there is a.
So coming back to the case, Shahana, we can proceed.
Yeah. Next, this is complete. The case. This is now. Then we have raised this case as because the 41 years bilateral ovarian tumor C125 raised, and it is a plus minus 2A 2B. For that reason, we raised this. We have presented this case today. This is the end of the case. The whole discussion completed. Yeah.
So the main problem here is the ovaries, I think. With the ovaries, we know the status of the ovaries.
This was presented here. Yeah. Thank you. Thank you.
Okay.
So,
thank you.
Yes, ma'am. But before that, we'll go for the 4 questions. But before showing the 4 questions, I request our 2 days, the presenting medical college Sherebangla Medical College, Borishal, and she's sharing the sessions. I request the head of the department from Sherebangla Medical College, Dr. Khurshid Jahan, to comment on today's program, to our program. Dr. Khurshid Jahan, please. Are you here, Dr. Khurshid? Probably she is not here. Okay. Next. So before ending the session, the Mahapus, please show the poll questions, and I request our scientific secretary, Dr. Kamaluddin Bhai, to comment on today's program. Kamaluddin Bhai, please.
I think enough comment is done today. So much lively discussion, and you brought out real tough cases, because what is tough for you, tough for everybody. So end of the day, the comment is that what is tough for one, tough for everybody. But yes, it was quite educational, and I'm quite happy to see the lively discussion from Shalini and Dr. Jaydeep, and also from Dr. Varun, and also thanks to Rupinder and Dr. Ahuja for joining us. And this type of support is always inspiring us to go ahead. And we know you people have quite busy schedule, and among the busy schedule, you are giving us time, and your time and your participation is always encouraging. And we are sure that every day we are learning slowly, we are educating ourselves, and the day will come that we can offer a standard treatment to our patients. And all the good suggestions from Joydeep and Shalini is well taken. We will really work on it. And as I mentioned, we will be trying to arrange some local and also overseas training for our faculties where we will be needing your help. So please keep on supporting us. And finally, all the participants, your participation makes the program successful. And I've seen the list, so many seniors of our country joined, and a good number of participants from India, I think, have joined. And I know one of my friends from Bhutan, Ugen, she's a very senior gynecologist from Bhutan. She sent me a mail that every week she is joining. So these are the inspiration. So please keep on supporting us. We, Oncology Club, will be continuing their endeavor. And finally, thanks to Shahan and your team for this wonderful arrangement. Thank you very much.
Thank you very much. Thank you, Dr. Kamaluddin Bhai. So thanks. I want to thanks to all our faculties. Regularly, you are giving us the supports. We are very much grateful to you. And I think at the end of this type of program, we shall include all our medical colleges, and all our medical colleges, our general gynae colleagues, they will get the ideal, the suggestion from you, and accordingly they will treat their patients, and obviously we will help them for giving training, and if possible we'll go there and we'll operate. And because of the COVID situation, we are not going there. And before that, the several times when they called us, we tried our best to attend their hospital. And in future, if they ask, and if you people will call us, we will try our best to attend your hospital. Now I request the president of the Oncology Club, Professor Dr. M.A. Hai sir, to conclude the session. Sir, please.
Ms. Anna. A really very nice session. And my thanks to the faculty from India for this suggestion they have given us. So we'll try to do this. You know, the Oncology Club is just a private organization. We have nothing to do with government. Most of the participants here are the government officers. There is some difference. However, we're trying to develop them to their skill. Most of the gynae departments are suited with gynae and obstetrics. Most of the time goes to work mainly managing obstetric problems. They get less time towards me. Even then, we are trying to sensitize them with the oncological problems. However, inshallah, hopefully we shall be able to do that. And thanks, my heartfelt thanks to everyone. Thank you all very much. Bye-bye.
Thank you, sir. Thank you very much. Good night, sir. Good night, ma'am. Thank you very much again, sir.
Thank you. Good night, everyone.
Can we leave? Good night.
Yes.
Okay. Good night.
Good night, sir.
Night.
Shahana kept you
Bye.
enough time. Shalini, you can leave now.
Thank you so much.
Thank you. Thank you. Thank you,
What
sir.
is the result of the quiz?
Yes, result of the poll questions. Mahfuz, please show the results of the poll winner. Dr. Afroz, Dr. Sylvia Hussain, she's today's presenter, and Namka Durji. Namka Durji, he was trained in Bangladesh from BSNMU. Now he's from Nepal. Dr. Namka Durji. Yes. Thank you. Thank you, all the winner.
Namka
Congratulations.
is from Nepal, or is he from Nepal or Bhutan?
Probably Nepal, Bhutan, I don't. Nepal, probably, as far I know. Nepal. Namka, probably Nepal.
No, I think he's from Bhutan.
Dorji, Namka, from Bhutan.
Okay. Can we end the session?
Yes, please.
Yes, Mahfuz, please end the session.